everyone, my name is Tashelle and welcome to The Journey. As you can see, today we're going to be talking about diabetes mellitus, which is also known as DM. So if you hear me refer to DM, we're talking about the same thing here, okay? So before I get into what diabetes actually is, I want to get to the point of knowing how the body naturally works. Sometimes when you know how the body works, you can kind of see where the disease disrupts the natural process of how the body is working. So to begin with, we always eat to get fuel, to get energy, because the body needs it, right? The cells need it in order to keep continuing and moving on and doing natural functions throughout the day. So as we eat, carbs in particular, because diabetes affects the glucose, right? When we break that down in our body, it turns into glucose, which the body then uses those as energy once it's turned into ATP. So in order for the body to break down the food, it needs help with the beta cell as far as the sugars component. So here I have two pancreas, and I did a visual drawing for those of you guys who are visual learners. I myself is also a visual learner, and sometimes a picture is 1,000 words. When you can see a picture of how the disease is working in your brain, it makes study session a whole lot easier, okay? So I'm gonna begin here with the blood glucose, okay? So this blood, I'm gonna draw a little picture here, all right? I'm gonna put it in red so it shows this is the bloodstream. All right, so like I was talking about earlier, we eat food, right? We have carbs. And once that carb is broken down into the glucose, right, they're now in the bloodstream. Now, you have cells that rest outside of the bloodstream that needs to get this sugar so that way it can turn into ATP so it can have the energy to continue its function, right? So how do we get all of this sugar into the cells, right? We go through this process within the pancreas, okay? There's a region called islet of Langerhans. And within the islet of Langerhans, you have two different types of cells. You have beta cells and you have alpha cells. Right now, I'm gonna focus more on the beta cells. And within the beta cells, it's going to secrete a hormone called insulin. Once that insulin is now secreted, that insulin is going to work as a vehicle to get all of these sugars into the cell. So now insulin is secreted. These sugars that were once here, right, are now guided into the cell. And the cells are happy because they're getting the energy that they need to continue doing the tasks that they have to do throughout the day, right? As you can see, there's still other sugars, right? Which those other sugars, once you have an excess of sugars, they are going to be stored in the liver. So I'm just going to take away some more, okay? And they are going to be stored right here in the liver. And that extra stored glucose is called glycogen. And the body pretty much puts some away just in case something was to happen. The body always likes to have a just in case moment, okay? So the liver stores that extra sugar. So now, let's say I haven't eaten breakfast, or I've skipped a meal, or what happens when I'm sleeping overnight, right? And I don't have the energy or the glucose that I need because I'm not taking in all of those glucose. Well, this is where the alpha cells play a part. And what the alpha cell does is in the same location, the islet of Langerhans within the pancreas, okay? It is going to secrete glucagon. And what glucagon is going to do, it's going to stimulate the liver to say, hey, remember all that extra sugar that you had? We need that now because, you know, we still have to continue doing our tasks and they haven't eaten, we haven't gotten any food, we need fuel. So the liver goes ahead and gives up that glycogen. Once that glycogen is then given up, it turns back into glucose, right? And then from there, it is able to, and I'm going to draw on this side, my bloodstream, okay? And it is going to put the sugars back into the bloodstream, okay? So this component deals with lowering the blood glucose level. This component deals with raising the blood glucose level, okay? So they're both in the same location, the pancreas. One is working to lower, the other is working to raise, okay? All right, So now I'm going to go ahead and continue. You have it on pause?
I'll just stop it?
You stopped it?
Yeah, I'm going to stop it now.
Stop. What diabetes is. Okay, so diabetes is just an increased level of glucose that is happening in the bloodstream because of defects in insulin secretion, the insulin action, or both. Okay, so now we have 3 different types of diabetes. As you know, we have type 1, type 2, but sometimes we forget about gestational diabetes. Okay, so type 1 occurs mostly because of a destruction of beta cells. Okay, so like we were saying earlier with that drawing where you have in the pancreas, the beta cells is responsible for secreting the insulin. Well, here there is a destruction, okay? And the factors that can play a part of why this is happening or occurring is because of either genetic factors, immunologic factors, or environmental factors, okay? And you will mostly see this in your young and slim people, okay? Not because, oh, if you're slim, you're going to get diabetes, but it tends to be one of the side effects of type 1 diabetes, that they're very, very slim. They have a lot of sudden weight loss, okay? So back in the day, they used to call this juvenile diabetes, but they can no longer call it juvenile diabetes because it doesn't just only happen in kids, but the new onset or the first onset of it normally happens in adolescence or as young as middle school, okay? Then you have type 2. So with type 2 diabetes, this is the one that is more common, okay? And with this, it's pretty much your body's still able to produce insulin, but it's either producing insulin that is going to be resistant. And what it means by being resistant is, remember, insulin is the vehicle that gets glucose inside the cell, right? So think of insulin resistant as either a broken down car. So it'll get you there, but not all the way there, you know, so eventually you're stuck, right? Or think of it as opening a door and you have a bad key and it's not able to open the door, okay? That's insulin resistant. Those 2 receptors that would kind of lock together to open the cell for the glucose to get in, there's trouble there, okay? And that's what insulin resistant means. And then the other problem could be either there's a lack of insulin being secreted or it's impaired, okay? So either or is the definition of type 2. And you will normally find this in your older patients and your obese patients. And older as far as 30 years of age, okay? Now, more and more children now in this generation have been obese and have been experiencing type 2 diabetes. So now it's no longer, that's why type 1 is no longer called just juvenile diabetes, because kids are now also exhibiting type 2 diabetes as well, okay? And the very last one is gestational diabetes. Now, gestational diabetes, hint, hint, gestational, all right? So this happens only through pregnancy, all right? So for the fellas, you don't have to worry about getting gestational diabetes, okay? But for the females, this is just an added thing that we have to watch out for. So pretty much you get diabetes because you're pregnant, okay, in other words. And the reason why you're getting it is because of the placental hormones. Okay, so your body's giving off these placental hormones, your body's not able to react with it, or it's reacting in a weird way where you're now becoming insulin resistant, or the insulin is not working properly. So now you're left with having high blood sugar in the bloodstream and affects you around 24 to 28 weeks. So those of you guys who are pregnant, most of the time when you're getting your prenatal care done, they would do this testing around 24 to 28 weeks because that's when it normally happens. Okay. And while you are pregnant, they will be giving you insulin, which I'll talk about later on, okay? And then once you've had labor, you've given birth, it is gone, okay? The diabetes just goes away, which is a good thing, okay? But it leaves you with a higher risk for type 2 diabetes later on, okay? So to prevent that, you want to make sure that you're eating good and that you're dieting and exercising, okay, the way you're supposed to be. But again, there are times where it does not go away for some women, okay? And I've experienced that. I remember back in nursing school, my second clinical rotation in Med-Surg, and I had a patient, and she had gestational diabetes, and once the baby was born, she was left with type 2. So sometimes it can go away, and that's the more common occurrence, is that it does go away, but later on you're at risk for type 2. So one of the ways to remember which is the most common one, because sometimes that is a test question, or your professor wants to make sure that you know which one is the most common one, is type 2. Type 2 is going to be your most common, okay? Type 1 is the second most common, okay? Now with type 1, the way how you can remember it is people who are young and skinny. Look at the number 1. 1 is slim, okay? So you can think of your young and skinny. 2 is bigger than 1, so 2 is your obese patient. 2 is also larger and bigger, so that's why you have old. Old and obese, okay? Young and skinny, okay? Just a trick to remember which one is more common and what appearance would you see in a patient who has diabetes, okay? So now we're going to talk about the clinical manifestations, okay? And clinical manifestation, just a fancy word to say signs and symptoms, okay? Which is abbreviated SS. So if you see that anywhere in the hospitals or anything like that, that's signs and symptoms, okay? And like I always like to use, okay? The most you compare, the better, okay? And with clinical manifestations, you get a 2-for-1 deal here, because your clinical manifestations are your nursing assessment, okay? What are you going to assess as a nurse? Whatever the patient is presenting, right? Their signs and their symptoms is what you're going to be assessing as a nurse. So if you know your signs and symptoms, you already know your nursing assessment, okay? So first things first, a normal blood glucose level, right? First we need to know what that is, which is 70 to 110, okay? Anything beyond that or below that is either going to be hyper or hypo, okay? Now, hyperglycemia, because we're talking about glucose here, okay, is a blood sugar that is greater than 110, all right? Now, with hyperglycemia, what are you going to see a patient exhibit, okay? Which you have the 3 famous P's, all right, which are going to let you know if this patient has high blood sugar, okay? You have polyuria, polydipsia, polyphagia, all right? Poly means many, urea is urine, so you're going to have increased urination, you're going to have increased thirst, and you're going to have increased appetite, okay? You're also going to see the patient complain about being hot and dry, all right, which makes sense. So how I like to remember is not by memorizing, okay? I like to get a picture in my head and kind of get a story and connect that story together. Once I get a story, I'll always remember that story. Memorization, you're only using your short-term memory, eventually is going to go away. And you still need to remember all this information. Why? Because you still got an NCLEX to take. All right, so here's the story. If my sugar is extremely high, right? For one, remember that picture that I showed you guys? Remember, if all of that sugar is in the bloodstream, the cells are going to be starving because the cells are not getting that sugar. So all of the day-to-day activities and reproducing that they're doing they're not able to do those things because the sugar, the energy that they need is not given to them. So those cells are going to be starving. So they're going to send a signal to the brain saying, hey, we need food. What's going on? So you're always going to be hungry, complaining of, oh man, I need a snack. I need this. I need that. You're always going to be hungry. All right. Another, because you have all of that sugar in the bloodstream, whose job is it to filter out the bloodstream? The kidneys. So now the kidney is going to have to work not just its regular function, but it has to work overtime. And working overtime means that it has to produce more and more urine because that's how we filter our blood, by urination. So you're going to have an increased urination, right? And then what happens when I'm losing all of that fluid, right? Because I'm constantly dumping it out when I'm going to the restroom, right? Eventually, I'm going to be thirsty. Why? Because our body needs fluid, so that way the blood is able to flow, right? So that's the picture that you can kind of get to remember. Hey, this person is going to have polyuria. This person is going to have polydipsia. This person is going to have polyphagia. Okay? And then they're going to be hot and dry. Dry because of the fact that you're losing all this fluid because you have increased urination, and then you're going to be thirsty. All right? So one way to remember is I'm hot and dry, my sugar is high. So if you ever have a patient, who's a diabetic patient, and they're telling you, man, I'm just so hot and dry, and they're exhibiting these signs, remember this saying, I'm hot and dry, my sugar is high. All right, that's one thing that I learned in nursing school, my professor told us about, okay? And if you don't like that one, you can switch it around. I'm dry and hot, my sugar is up, okay? So whichever one works for you, it's completely fine, okay? Now we're gonna talk about hypoglycemia, okay? Now, hypoglycemia is a blood glucose that is less than 70. Now, you're not gonna start treatment until it's less than 60, at least that's how most hospital protocols are, but remember, anything outside of this range is either going to be hypo or hyper. So it's outside of the 70 range, so anything below 70 is going to be considered hypoglycemia. Treatment doesn't start until 60. All right? Now, signs that you're going to be exhibiting are headache, hunger, confusion, dizziness, weakness, cool, clammy skin, right? Or moist skin. And then you may have tremors. All right? Now, a way to remember this is thinking about the times when you're hungry, right? Most of the time when you're hungry or hangry, a lot of people get hangry, I know I do sometimes, but you may get a headache, right? You may get confused, you may have some dizziness, right? A lot of people think that, oh man, I haven't eaten, I can't think straight right now, or I haven't gotten my intake for the day, don't talk to me because I'm not functioning, I cannot think, right? So, confusion. You may feel a little lightheaded, right, when you haven't eaten for a while. You get dizziness, right? You may feel weak. Lethargic is just another word for weak. So if you see them work interchangeably, it's the same thing, okay? And then the only thing that's new that may be a little bit different that we may not experience is the fact that you may have tremors, right? And you may have cool, moist skin, all right? So other than that, the rest of these symptoms are kind of typical day-to-day things that we may feel ourselves when we haven't eaten. Okay? And then, here's a saying to kind of remember hypoglycemia. All right? I'm sweaty, cold, and clammy. I need candy. Okay? Sweaty, cold, and clammy. I need candy. All right? And if you don't like that one, I switched it around. I'm sweaty, clammy, and cold. I need some food. So, I like the first one better than the second one. But, hey, you'll be surprised what you will remember. Okay? Maybe it's the food saying that you get. Okay? But just remember, hypoglycemia, all right? The main thing is the cool, clammy skin, okay? And cold. They're going to complain of being cold. They may have tremors, okay? So you want to make sure that their blood sugar levels are at normal, okay? Okay. So now we're going to continue on with the signs and symptoms, okay? So like I talked about earlier, remember, in type 1, you're going to have weight loss, and it's going to be sudden, okay? That's the key word, sudden, because we all have weight loss, right? So that doesn't mean we all have diabetes. But if you see a sudden weight loss, so this can be a patient who's 200 pounds or 150 pounds, and all of a sudden they've lost 40 to 50 pounds within 3 weeks, right? Or a week or two, right? Anything that is sudden, drastically sudden, okay? Also, vision changes, okay? Dry skin, numbness of the extremities, okay, which are you may have of the hands and feet more often within the legs and the feet area, okay? And then slow wound healing is another sign and symptom. And then reoccurring infections, okay? So later on, as I get deeper into the lecture, you will see why these are the signs and symptoms based on complications of the disease process, okay? So here's the cool way to kind of remember. Those of you guys who like mnemonics, they can be very helpful at times, okay? So as you can see, this mnemonic is sugar with 2 R's, okay? And S is for slow wound healing, okay? U, because of the blurry vision, okay? Glycosuria. Glycosuria is pretty much glucose in the urine, okay? Now, normally you're not really supposed to have sugar in the urine, so they would judge a patient who may be exhibiting glucosuria and see how high are those levels of glucose in the sugar, okay? I mean the urine, okay? You may have an acetone breath, which I'll go on later on and let you know exactly why this is occurring and how it's happening, okay? They will have an acetone breath. So girls, you know the nail polish acetone? Yes, their breath will literally almost smell like that, all right? Rashes on the skin. And then again, like I said here, the reoccurring infections. Okay, so this is sugar, this is a mnemonic to kind of help remember the signs and symptoms of a patient who has diabetes. Okay, so So now we're going to talk about the diagnostic testing, okay? So now that you've seen this person and they have these signs and symptoms of diabetes, right, you want to make sure that you have an accurate testing to figure out, hey, do you have diabetes or don't you have diabetes, right? Because sometimes those signs and symptoms can just be vague. So you want to actually have a diagnostic testing that can examine and let someone know if they do truly have diabetes, okay? So we have 3. First up is the fasting plasma glucose testing, and as you can see, it's in the name, okay? Fasting, all right? So fasting requires you 8 hours of no intake, okay? So this is typical when you're sleeping or so. You'll go to the doctor's appointment once you wake up in the morning. Make sure that you haven't eaten any breakfast or anything, only water. And you'll be fasting for 8 hours. And when they go ahead and check your blood glucose, anything greater than 126, okay? You may wonder, oh, 126 is not that bad. But yeah, you've been fasting for a whole 8 hours. So for a whole 8 hours, you didn't have any intake, and it's over the range, okay? So anything greater than 126, okay, is more so on the lines of you may be a diabetic, okay? This is the most common one that they use, so I'm gonna put a star next to this one, okay? This is the one that they use most often, all right? And these other 2 is just good to know, but they don't really use it when you go into the doctor's office or you're going for a checkup or so. They mainly use the fasting plasma glucose, okay? But I'll still mention it so that way you guys know about it. So you have the random test. And random test, again, it's in the name. Your blood glucose level is going to be taken at random, and pretty much means anytime. As long as your blood glucose level isn't greater or equal to 200, you're in a good range. If it is greater or equal to 200, you have the risk of maybe having diabetes, okay? And then you have a 2-hour post-load glucose. Again, the name, okay? And then post-load, which means after. So 2 hours after taking in glucose, okay, is the name of this test. And pretty much what they're going to do is that they're going to put 75 grams of glucose in water, and then after 2 hours of you consuming that, if you have a blood glucose level greater than or equal to 200, then you may also as well be exhibiting signs of, having diabetes, okay? Now, this, again, I told you this is the number 1 choice that they like to use, but again, these are 2 other testing that they can do. If you've noticed, these 2 have the same exact results, okay? Anything greater than or equal to 200, okay? So that kind of makes it easier to remember, right? And then the fasting glucose is anything greater than 126, all right? Now, here in this little cloud, all right, one of the lab works that they can do to see if you also are a diabetic is your A1C. Now, some of you guys probably have heard of that before. They also call it HA1C, all right? But what this lab is doing is pretty much checking your blood glucose over a 3-month period. Now, you may wonder, wow, how is it able to check it within a 3-month period? Well, remember, how long do your red blood cells last? 3 months, right? Every 90 days, they die off and they regenerate, okay? So within that 3-month period, right, your red blood cells, all right, are able to tell the doctors or whoever needs to know how well you've been doing. So you may say, oh, I've been doing really good today, right? And your blood sugar is in range, but you cannot cheat this test, okay? So this test will let the doctors and whoever else know, any healthcare provider know exactly how well you've been controlling your blood glucose level, because your A1C does not lie, all right? It tracks 3 months, all right? So it's not just a day or 2 or a week or 2, 3 months. So now we're gonna go ahead and talk about the complications of DM, all right? Now, one of the complications is DKA, which DKA pretty much stands for diabetic ketoacidosis, okay? And with this complication is mostly seen in a patient who has type 1 diabetes, okay? Now, you may be saying, what is DKA? Well, it is a life-threatening condition, okay, that is to be taken very seriously because people do die from this, okay? And what it is pretty much the body's unable to get the glucose, right? So remember, like I was saying in the diagram earlier, right? This is your bloodstream, and you have all the sugar building up here, and the cells are not able to use that sugar as energy to continue its day-to-day function, right? So what happened is the cells are going to trigger a signal to the brain saying, hey, what is going on? We need to survive. We are depleting. We need energy to continue our task. We need help, right? Now, normally in a normal body function, the body is going to take the extra sugar, right, store it as glycogen, and then put it in the liver. Once the liver has the max capacity of the glycogen that it needs to store, anything extra than that becomes fat, which is why a lot of people have more fats in different places, because depending on the amount of intake that you're taking in and what the body's actually using. So anything extra is going to be stored as fat, right? And the body knows that. So what the body is going to do is say, hey, if we can't get access to this sugar, because remember, type 1 diabetics don't have any insulin whatsoever, right? So if there's no insulin, this sugar would never get to the cell. So the body said, hey, well, since we can't get the sugar from here, there's only one other place that we can get it from, which is the fat. So the body gets the sugar from the fat. When the fat is broken down, right, it releases a product called ketones. And those ketones are now released into the bloodstream, which makes the bloodstream very acidic, right? So when the bloodstream is acidic, So when the bloodstream is acidic, right, this is where all the problems starts to occur, all right? Hence the word acidosis, ketone acidosis. Right here, ketones are acid, ketoacidosis. And of course it's diabetic because it's happening because the patient is a diabetic, all right? So that can also help you by just seeing the word, what is going on. There are ketones in the bloodstream that is causing the bloodstream to be acidic, all right? And from there, this is where you get the fruity acetone breath. So remember when I was showing you the signs and symptoms and I was telling you, you'll begin to see why you get these signs and symptoms, okay? Because one of this complication here causes those signs and symptoms. So you will have the fruity acetone breath, okay? Because the acetone that is protruding from the ketones from the acidic levels in the blood, okay? So what the body's going to try to do is going to try to compensate for all this acid that's building up inside the blood, and you have a thing called Kussmaul breathing. So your body is going to compensate by breathing deep and fast. So it's going to be something like this, right? And the reason why you're doing that is because your body is trying to release that CO2, right? And the more CO2 you're able to put out faster and faster and faster, it helps to deal with the acidic level, okay? So that's the reason why you have the Kussmaul breathing, because the body's trying to compensate to decrease the acid level, all right? And then from there, your treatments, okay? So these are the signs and symptoms that you're going to see in the patient who has DKA, all right? It's a life-threatening condition, and you get the understanding of that, all right? And now the treatment. So your treatment, you're going to have fluid replacement, okay, electrolyte replacement, and then insulin, okay? So for electrolyte replacement, for fluid replacement, you may use normal saline, and you may use half normal saline, or you may use D5W once you've already used normal saline or half normal saline. Now you may wonder, the sugar is already up. Why am I using more sugar, right? Because when your body is now receiving all of this extra fluid, right, you don't want your body to then go into a rebound state where it's like, hey, we're depleting of sugar. We need more sugar. We don't have sugar. The next thing you know, we have hypoglycemia. So the body, so the doctor would order D5 to kind of make sure that it stays at a consistent level where the body is able to at least have some sugar in the bloodstream so you're not experiencing hypo. The next you're going to have is electrolyte replacement. Now you may think, what does electrolytes have to do with this? Right? Well, potassium plays a big part because potassium helps aid sugar into the cells by the work of insulin. Okay? So your potassium levels may be depleted, okay, because your potassium is helping constantly to get those sugars into cells. All right? And the last thing is you're going to use insulin. All right? And your insulin, the one that you're going to use is regular insulin because, as you know, regular insulin is the only insulin that can go IV. And you have Novolin R and Humulin R. So the next complication that we're going to talk about is called HHNS, okay? And pretty much what that stands for is, hold on because this is a mouthful, okay, hyperglycemic, hyperosmolar, non-ketonic syndrome, all right? So you get the drift. HHNS is the better way to go, okay? But pretty much within this, it's pretty much saying high glycemic, okay, non-ketonic syndrome, okay? So the main thing we need to focus on here is this word right here, non-ketonic. That is going to be the biggest difference between this one and DKA. Another thing as well, this is mostly found in type 2 diabetics, where DKA was found mostly in type 1 diabetics, okay? Now, with that said, it increases the blood glucose levels, okay, without ketones. And without the ketones, there won't be any acidosis, okay? So this one, it does the same effect. It's an increase in the blood glucose level, okay? But this one is non-ketonic. So the reason why it's non-ketonic is because your body is still producing some insulin, okay? Even though the insulin may be a little bit resistant or maybe a lack of insulin, the body still nevertheless have some insulin. And with some insulin, that means some of the sugars are able to get into the cells, okay? So I'm just gonna draw here. Okay, this is my bloodstream. All right, these are my cells. And these are all the sugars, right? Now the body is still able to produce some insulin, so some of the cells are able to get some of the sugars, okay? So that way it doesn't signal off the brain to say, hey, you need to break down the fat. So it's not going to break down any fat because some of the cells are still able to get the sugar that it needs, okay? So with that said, all right, one thing you need to know is that with this treatment, insulin doesn't really have to play a big part, only because your body's already producing some insulin as it is, okay? So it's able to at least aid some of the sugars to get inside, okay? So the main thing for treatment is going to be fluid replacement, okay? Rehydration, 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 okay? Which is why in the name it's hyperosmolar, all right? So you want to rehydrate this patient. And what are you going to rehydrate them with? Fluid, as far as normal saline. You can do half normal saline. And once you do either or whatever the doctor orders, okay, then you can go ahead and then give D5W afterwards, just so that way you don't bottom out that patient and now they become hypoglycemic. You know, so you want to make sure that they're able to still get the sugar that they need, so that way they can have an even level of blood glucose in the blood, okay? So this is the main treatment, is rehydration. Now, you may see some doctors, they may go ahead and give potassium replacement as well, and they may give insulin depending on the patient, but again, the main thing is rehydration, all right? Some patients may not respond as adequate as others when it comes to treatment, so therefore you may see multiple steps in other patients, okay? So they'll start with this, they may do a fluid bolus, and a bolus is pretty much just 1,000 mLs infusing into that patient over an hour, okay? So they may do 2 boluses, 3 boluses, whatever the doctor orders, okay? And then from there they'll monitor to see if the blood sugar is going down. If they need to intervene and do more treatments, then they'll go ahead and maybe do potassium replacement, and then from there they may decide whether or not they need to do insulin. But for the main thing is rehydration, okay? And the difference between this and DKA is that DKA is found mostly in type 1 and HHNS is type 2, okay? DKA has ketones, okay? HHNS doesn't have ketones. And most of the time they characterize a person who's going through these complications with a blood sugar over 600, okay, for both DKA and HHNS, at least according to the Suddarth book, okay? So anything above 600, you're going to encounter these complications for type 1 or type 2. So now we're going to go ahead and talk about other complications with diabetes. You have the Dawn phenomenon, you have insulin waning, and then you have Smogy effect. So the first one I'm going to talk about is Dawn phenomenon. And as you can see here, Dawn phenomenon starts within the hours of 5 a.m. and through 8 a.m., okay? And what happens is pretty much you have a normal blood glucose up until 3 o'clock in the morning, okay? Then around that time, your blood glucose level starts increasing as you're awakening in the morning, okay? So around 3 o'clock, it is rising, and from there, when you wake up in the morning, you experience hyperglycemia. Okay? The treatment, I'm going to get back to the treatment. Okay, so the next one is insulin wanding. All right, insulin wanding happens from bedtime to the morning. So the blood glucose level is constantly rising from the time you've gone to bed throughout the night and when you awaken in the morning. Okay? So again, the results is going to be hyperglycemia. Last one, Smoggy effect. Okay? Now, Smoggy effect is a little bit different. All right? This happens between 2 to 3 o'clock in the morning. Okay? You may have normal or an elevated blood glucose at bedtime. Okay? But then all of a sudden, around 2 or 3 o'clock in the morning, okay, there's a drop in your blood glucose. Okay? So you become hypoglycemic. And the body senses that, so its way of compensating is going to then increase the blood glucose level, but in it doing that, it rebounds it so much that when you wake up in the morning, you have hyperglycemia. So as you can see, the dawn phenomena, insulin wanding, and Smoggy effect all has the same results, is that when you wake up in the morning, you are going to have hyperglycemia. Okay? Now, how it's working is different. This is happening at 5 to 8 a.m. in the morning, and it only starts rising from 3 o'clock in the morning, okay? Which makes it different from insulin wanding, where insulin wanding, it's been rising from the time you've decided to go to sleep, from bedtime, okay? Till morning. And then finally, Smoggy effect, there is a drop in your blood glucose. This is the only one that drops, right? And then eventually your body wants to have a rebound, so it rebounds itself and says, hey, we need more sugar, produce too much sugar, and ultimately results in hyperglycemia. So each of them ends the same way, all right? Now you may wonder, what is causing the increase, right? Well, researchers have came up and they say it is because of growth hormones, okay? Where some of your growth hormones are found in your adrenal glands, and when you have cortisol, all right, excuse my spelling, okay? You have the actual growth hormone itself. You have adrenaline, which consists of norepinephrine and epinephrine. Okay? So, okay? So this is what researchers are saying is the cause of the increase, okay? Because of the growth hormones, whether it's cortisol, the actual growth hormone itself, within the adrenaline you have the norepinephrine and non-epinephrine, okay? That are secreting these mechanism of what is going to end up resulting in a high blood sugar, okay? So how do we treat it, right? So for dawn phenomena, what we're gonna do is simple. Just change your intermediate, which is the NPH insulin, okay, which I'll go over later on about the different types of insulin. But you're going to change your intermediate insulin, all right, from dinner time to bedtime. So to fix this, I'm just going to give insulin at bedtime. So that way, this insulin works over a period of time, okay? So once I give this insulin, when 3 o'clock strikes and the blood sugar wants to go up, because I've now switched to insulin, I've given it at bedtime, that insulin now has coverage through the 3 a.m. to the rest of the morning. So this resolves this problem, okay? Insulin wanding, what I'm going to do for treatment is I'm going to increase the intermediate or long-acting, okay? Long-acting is also another type of insulin, okay? Dose, or I can add a dinner time insulin, okay? So with that being said, because it's already rising from the time of bedtime, I'm going to either increase the dose of insulin that I have already now, so that way throughout the night when it wants to increase, that insulin helps to keep it steady, or I just go ahead and I add a dinner time. So right before dinner, you go ahead and you'll take your insulin, okay, and then you'll take your regular intermediate dose insulin throughout the night, okay, and that solves this problem, okay. And then the last one, the Smoggy effect, okay? With the Smoggy effect, how you're going to treat it is you're going to decrease the insulin, Okay? So as you can see here, this is an increase, this one is a decrease. So look at the differences so that way you're not mixing each of them up. I know it's a little bit hard because they all result in the same thing, hyperglycemia, but you have to know how it's happening, okay? And we already know why it's happening because they all have this in common. The growth hormones is all causing these changes, okay? So that's one thing that they have in common. But when it comes to Smoggy effect, I'm going to decrease the insulin, whether it's at dinner time or at bedtime, whichever insulin dose, I'm going to decrease one of them, okay? Or I can go ahead and add a bedtime snack because the only reason why this one caused hyperglycemia is because you had a dip at 2 or 3 o'clock in the morning and you were hypoglycemic. So instead of your body reacting to the hypo, you either decrease the amount of insulin that you're going to get that would drop it, or you just give a bedtime snack so that way throughout the night that sugar is able to still be digested and go into the bloodstream, so that way there is not a dip in the hypoglycemic effect, which will then cause a rebound, okay? So this is how you treat all three, and just try to look at the differences so that way when you get test questions, you know, and they say, oh, this is happening at 5 a.m., or this is happening from the time of bedtime, or this is happening at 3 a.m. or so, or if you hear rebound, you know which one is which. So we're still on complications here, all right? So the next type of complication we can have are macrovascular complications, okay? So macro meaning big, okay? So the first thing is artery disease, okay? When a patient has diabetes, you know, one of the things is they're going to have bad vessels, okay? Whether it's arteries or peripheral, they're going to have bad vessels. What's going to happen is that these vessels that were once flexible are now going to become hard and very stiff-like, okay? And anything that's hard and stiff-like, you're going to encounter different problems, okay, with the arteries, okay? So that's one thing that you're going to experience from a diabetic, is that they're going to have bad vessels, okay? Again, cardiomyopathy, okay? The heart plays a big part because if the vessels that are supposed to bring blood to the heart are not working at their optimal level, who else takes a suffering in it? The heart, because the heart then has to take that blood and then perfuse it throughout the body, okay? So that heart now has to work overtime, which can cause problems over time with a diabetic. So one thing, I don't know if you guys ever experienced someone who has diabetes or know any family members who does have diabetes, because it's a very common disease, you'll notice that they may have comorbidities as far as different complications of different parts of the organs, all because of a result of diabetes, okay? So when it comes to the heart, one of the things that you may see with a diabetic is that they may have congestive heart failure, right? They may experience an MI because of the diabetes. So that's one of the complications that can arise because of being a diabetic, okay? So just remember that. Hypertension, okay? This is the abbreviation for hypertension, and hypertension is just pretty much an increase in blood pressure. Now, one way how I like to think about diabetics having increased blood pressure is think about the blood, right? And I have the blood here, and I have all this sugar, right? These are my sugar, right? I think of this like syrup, right? You have all this sugar here into the bloodstream. It's very, very sweet, right? One thing that I can think about is sugar, right? Or molasses, whichever one. And you want to take that bottle of syrup and put it on a plate. When you turn that bottle over and you open that syrup, it's going to go very, very, very slow, right? And because it's going very, very slow, what do you need to do to make sure that all of that syrup gets on the plate? You squeeze. And when you squeeze, you increase the pressure for all of that syrup to come out. So you can think of it like that, okay? The blood is like syrup, right? And the body still has to perfuse, you know, the different organs in the different areas, and it has to do it by the transportation of blood that's carrying all the nutrients, right? So eventually, the body is going to compensate that by pretty much increasing the pressure to get the blood wherever it needs to go. So think of hypertension, increased blood pressure, right? That's a complication that's happening on a macrovascular level because the patient is not able to perfuse properly, because I have these artery disease and peripheral diseases and things like that, that I need an extra boost, I need an extra help. So your body is going to raise the blood pressure so that way you can get adequate perfusion, okay? Now, you have cerebral vascular disease. Now, you may think, what does the brain has to do with diabetes, okay? It has a lot to do with diabetes because one of the things that can happen is you can get a stroke. You get a stroke and you have different types of stroke. You have an ischemic stroke and you have a hemorrhagic stroke, which I'll discuss later on a later time, okay? But with high blood pressure is one of the reasons why people can have a stroke and have cerebral vascular diseases, okay? Because within the brain you have very tiny vessels. And with those vessels, right, they can only take a certain amount of pressure. And if you have high blood pressure, eventually you can cause those vessels to rupture. And when those vessels rupture, right, you have a bleed, so you can have a hemorrhagic stroke, or you weaken the actual vessel in itself, and you may get an aneurysm where there is a bulging of the actual vessel in itself, okay? So this is where the cerebral vascular problems can occur. And then also, you have chances for clots, right? Because one thing with the arteries, they no longer are straight or, you know, as part as the original anatomy, right? They may come crooked, they may come swirly, especially if you have a patient who's on dialysis because of all of that pulling and tugging onto those vessels, right? Those vessels now become squiggly, and remember, anytime blood is next to each other, what happens? They begin to clot, right? So in those areas, instead of having a straight blood flow, you may have areas that are crooked and it's turning, right? And those blood mixes and gets caught up with one another, and you can get a clot, right? So with those clots, you know, those clots then travel. And as they travel, it may just hit the brain, or it may just hit the heart, all right? So keep in mind, you know, with these complications, these major organs can also play a part in deteriorating as well, okay? And then the last but not least, peripheral vascular disease, which is mostly common with a lot of diabetics. And if you guys ever experience having to draw blood or having to start an IV on a diabetic, they have very poor peripheral sites that you can see. Most of the time they have a graft, or they have an AV fistula, or they're on dialysis, right? Or they'll tell you, hey, don't do this arm, there's nothing on this arm, you have to do this arm, okay? And a lot of patients will tell you that because they know for themselves that this arm is just horrible, or whichever arm is horrible, because they have poor peripheral vascular perfusion going on, okay? So the veins plays a part as well. You may not get a lot of blood return when you're trying to get blood. The veins are very hard to see. Again, the vessels are damaged, okay? So these are the different complications that can occur on a macrovascular level, okay, to these major parts of the body. So last but not least, we're going to talk about macrovascular complications, okay? And within macrovascular, we have three main ones, which is retinopathy, nephropathy, and neuropathy, okay? Or neuropathy, however you want to pronounce it, but neuropathy. Okay, so the first off, we're going to talk about retinopathy. Retina means eyes, okay? So within the retinopathy, what happens is there's a rupture of the retina vessels, okay? And remember, like we were talking on the previous slide, remember there's a hypertension that's occurring, high blood pressure, and it's not just only in the main arteries or vessels, but it's also happening even in those tiny areas like the brain and the eyes, okay? So the eyes can't handle that type of pressure, so what happens is those vessels begins to rupture. And then once they're ruptured, that blood is not perfusing to those areas for those cells to regenerate and do the function they're supposed to do. So what happens is there is a blindness or blurry vision, or ultimately it's going to lead to blindness, but you may start seeing the different changes of the vision changes. So I don't know if you guys remember, but remember in the signs and symptoms, that sugar, remember the one that was under you, blurry vision? Well, this is where this comes from. So like I was saying before, your signs and symptoms occur based on the complications of diabetes, okay? So these are what is going to present in a patient who is a diabetic, all right? And neuropathy, and retinopathy is the main one, okay? That can cause changes in the vision, all right? And what you will want to do to help prevent or control that is you want to make sure that the blood pressure is maintained, that it's controlled, okay? So you may see some diabetic patients that they're on multiple medications because of the complication that results from diabetes. So you'll see them on blood pressure medication, okay? Not because they naturally have it, but because the diabetes is causing high blood pressure, okay? So you want to make sure that the blood pressure is controlled, and you also want to maintain the blood glucose, because what is ultimately causing the high blood pressure? The glucose in the blood, okay? Remember that analogy of thinking of it as syrup and the body's trying to squeeze to perfuse everything, so the pressure is going to go up, okay? All right, next one is nephropathy. Nephro, all right, is kidney. So we're talking about the kidney function, okay? And this is why a lot of diabetics, you see them on dialysis, or they have a bad kidney, or they need a kidney transplant, right? So this results in you checking your lab levels, and your 2 lab levels that would definitely tell you how well your kidneys is functioning is your BUN, also known as BUN, and your creatinine. They go hand in hand. It's like peanut butter and jelly, okay? Wherever you see BUN, you're going to see creatinine. Wherever you see creatinine, you're going to see BUN. They are the 2 labs that are going to tell you how well the kidney is functioning, okay? So a normal BUN level is 10 to 20. So anything outside of that is a problem. Anything above that is a major problem, okay? Creatinine, 0.5 to 1, okay? And you want to make sure that these levels are consistent, okay? Or at least stay down in lower levels, okay? Also, you want to avoid nephrotoxic medications. And nephrotoxic just pretty much means that they're toxic to the kidneys, okay? And you are going to have some medication that are going to be toxic, okay? Not meaning that, oh, you take it one time and it's going to damage the kidney. But remember, when the medication comes inside your body, it has to be metabolized. It has to be broken down. How is it broken down? Through the liver, through the kidney, okay? So there are some medication that works directly and it metabolizes in the kidney. So the medication that metabolizes right directly to the kidney, you want to be careful of your consumption of those things. And some example is gentamicin and vancomycin. These are antibiotics, very common antibiotic, very strong antibiotics, okay? And these are going to ultimately, all right, decrease your kidney function a little bit just because it's being metabolized in the kidney. So the kidney has to work overtime, okay? Okay, and then also too, you just want to be careful with your dialysis patient, because again, if they're on dialysis, it's either one or 2 things. Either the kidney is completely not functioning, or it's not functioning well enough to produce an adequate amount of urine output, okay? So yes, you can be on dialysis and still have your, still urinate as well, but you may not be putting enough to filter all of the blood, so then that way you're on dialysis, okay? So another thing with nephropathy, you definitely want to make sure you're being sensitive to your dialysis patient, as well as the drug choices that you are prescribing these patients, okay? And then last but not least, you have neuropathy. And neuropathy deals with the central nervous system, okay? And within the central nervous system, right, you are going to have problems as far as non-healing ulcers, okay? Peripheral neuropathy, okay, which you'll hear a lot of diabetics complain, I have neuropathy, right? And you'll mostly get it in the lower extremities, all right? It's a possibility that it can be in the upper extremities, but I find it mostly common in the lower extremities, especially by the shins area and definitely the feet, okay? And then you're gonna have a decreased sensation, right? Nervous system, nerves, right? They're in charge of the tingling sensations that you may feel, and your reflexes, okay? So you're gonna have, ultimately, you can probably have paresthesis, okay, where you don't have any feeling at all, just completely numb. So remember when we were talking about signs and symptoms and we said numbness of the extremities? This is where this comes from, right? Neuropathy, this is a complication that results. And again, also, there's another one. Remember we said slow wound healing, right? So one thing I want you to know is that this complication can show up signs and symptoms of a patient who has diabetes, okay? So one thing you want to pay attention to is foot care. Big question they always like to ask nurses, especially on the test questions and things like that, is foot care, right? So one thing you want to do is inspect the foot daily, or tell the patient, make sure you're checking your foot daily, because if you can't feel any sensations right? And you're bumping into things and you're knocking your foot. You know how many times we stub our toes and we yell, right? But these patients can't feel that. So they stub their toe and they're bleeding or they have a cut. They're already gonna have slow wound healing, right? So to prevent that, you wanna make sure that they're checking their feet daily, all right? You also wanna make sure that they avoid hot water because they can't feel it, right? You can't feel the temperature, so just say, you know what, cool temperatures. Avoid hot water and avoid them soaking their feet, right? Because what happens when you soak your feet for a long time? Your skin in itself and the actual feet, the skin gets very, very, very soft, very brittle, okay? Which causes more problems because now the skin is extra soft, so it's easier to hit and bang your feet and then it opens up a wound, okay? And again, we're trying to avoid wounds just because if you do have a wound, it is going to heal very slowly, okay? Another thing, avoid tight-fitting shoes, okay? I know a lot of females, we see a cute pair of heels or shoes or whatever, and we feel as if we have to have it, right? So we'll squeeze our feet in there, we'll get corns on our feet, you know, just so we can look good for the night, right? But with a diabetic patient, you do not want to do this, okay? No tight shoes at all. You want to wear roomy, comfortable shoes, right? And hard, sturdy shoes, okay? So no open-toe shoes. You know, I mean, you can wear it every now and then, but to prevent any complications, further complications, any wounds from occurring, you want to make sure you have a good solid shoe, okay? And that is room, it has a lot of room, okay? Because again, the name of the game is to avoid wounds, all right? Also, when you're cutting your toenails, all right, cut them straight. A lot of times we like to curve, right, and get all the edges. And sometimes when you're doing that, you might just cause a wound because you may clip too low, okay? So they recommend that you just cut straight across, okay? Because that will prevent you from actually digging into your toes and causing you to get a cut, which is then going to do what? Slow down the healing process because you already have a slow healing of a wound, right? And then also too, when you're moisturizing your feet, right? When you're moisturizing your feet, you're putting on lotion. A lot of us, we like to make sure that we are moisturized from head to toe, and we want to go through each toes, each crevices. With a diabetic patient, you do not want to go in between the toes. Why? Because then it's going to build up moisture, and when that moisture is built up, the skin begins to tear. And with it tearing, again, go back to what? A slow healing process. And a lot of times you may see patients that are diabetics and they have a thing that's called ulcers, okay? And ulcers is pretty much just a wound, a breaking in the skin, and you can have stage 1, stage 2, stage 3, stage 4, and then unstageable, okay? Now, when they have these ulcers, they're called diabetic ulcers, okay? And pretty much you get them because of being a diabetic, all right? And you want to avoid this because what happens when you have broken skin, right? Your skin is your first defense mechanism of action of it protecting itself. If that skin is broken, I've already destroyed my first defense mechanism, right? So now I'm more prone to what? Infections, bacteria, different things coming into my body because I have a broken area. And remember, a regular person, they may have a broken skin, but within a couple of days, it's already healing. So, you know, that risk of having infection is less. But if a person who has diabetes and they have a slow healing process, something that would take 2 or 3 days to heal is now taking several months, right, or several weeks. So you have a more open window of infections coming in and invading your body, which is why you have the reoccurring infection, because by the time your body gets a chance to heal, here's another infection, here's another bacteria, okay? Which, remember, we talked about our signs and symptoms. The second R was reoccurring infections. So as you can see the picture coming together, that would kind of help you remember the different signs and symptoms, okay? As well as the complications of what's going on. That's why when you have diabetes, it is a multi-organ disease that is going to just not just only affect one part of the body, but several parts of the body, okay? So you want to make sure you keep your blood glucose under control. Okay, so stay tuned because I have part 2. This what I just went over here was part 1, which is pretty much talking about diabetes, the complications, the signs and symptoms, right? The diagnostic testing. Now part 2 is going to be how we treat diabetes. So I'm really going to be going over the medication, how they work. So that's the pharmacologic part of the diabetes. Just stay tuned for part 2, and I'll show you exactly what medications are used and what treatments are used to treat diabetes.